Doctorate level. I don't think it really needs sound. Okay, guys. You guys all ready? Perfect. Okay, so appreciate y'all participating in the panel and then obviously this as well. We are going to talk about the treatment and prevention of conduct and behavior related disorders. I'm going to add a little caveat. This should be the very last non-illustrated and annotated PowerPoint you ever see, right? I'm dating myself by not adding color and pictures and anything like that. So I apologize in advance. Hopefully I can add to it. More specifically, behavioral parent training, which some of the things we're going to talk about. I probably will find a natural break in this. We have a small enough group that I would love questions. I would love, there is some jargon in here when we get into the ABA stuff. Feel free, we can talk about that. We can break that down. There are going to be some things that I may kind of speed through, some diagnostic stuff. I think it's relevant in kind of setting the stage, but I don't want to spend an over time. I'd rather hear from you guys and be able to be receptive to what's going on. Okay, cool. And I talk fast. I'm cool with slowing down. Let me know. Raise your hand, yell, whatever you need to do. Cool. So, housekeeping, I just said that, all of that. Tell me real quick, just so I can have a survey, so I know my audience, so I can maximize the efficiency of this. Who are our audience? Where are we in our program? Cool. Practicum from which program? Okay, master's degree program. Perfect. Who all is in the master's degree? One of the master's degree programs. Cool. Okay. Any doctoral level students?
Doesn't.
Sure. Cool. Okay. And then what's your experience with conduct or behavior related disorders? Anybody? Zero.
I work in community mental health with kids.
Cool.
So there's like a lot of, not a lot of like diagnosis of conduct disorder, but like behaviors that are.
That you see.
Yeah.
Right. Okay. You may not, when we're little, still we may not have the application of a diagnosis, so we understand that. But you see the behavior.
Yeah, like the aggressions. I actually got bit one time.
Nothing going wrong. It's fun.
Yeah.
But we learn from it, right? Okay. Anyone else? Yes. Cool. Okay. What age? Elementary. Okay. Good deal. Perfect. Anybody else have any experience with these topics? Perfect. Okay. So then my goal is going to be able to kind of start from the ground and work up. Okay. So I included in this, the opportunity I put some case study stuff in there, some examples, which we may or may not get to. Apologize in advance. If we want to stay later, we can touch base with some of that. But hearing this and understanding the audience, I want to make sure we get good foundational information. We can identify if we even have interest in this topic to then maybe further explore for when you're out and about practicing. Okay, who am I? Okay, so I'm going to try to cover who am I relevant to this topic. My name is Cam Kramer. It's Robert Campbell Kramer. Don't call me Robert. I probably would not respond. You can say Cam or Dr. Kramer. It's easy. I grew up here in Corpus, went away, but came back, got my bachelor's and master's here through the psychology program. Worked for a while as an LPA and an LPC. I started working with a psychologist here in town, doing nothing but assessments in the juvenile detention centers, San Pat, Nueces County, and then in the evenings, groups, anger management, things of this nature. So that was my initial introduction to the field. Then as soon as I got my master's, maybe 2 months into it, took a job with the TexCHIP Commission, which is essentially past probation. So it's jail for kids. Kiddos from 11 to 21. At 21, they either would go out on parole or transition to TAMU-CC. And sometimes we had kiddos that were too young to be in the younger housed adult prison. The adult prison now takes 14 and up, segregated. And so we got some of those lesser crimes that maybe get some lesser attention, but the full gamut. There's nothing that you can think of that I haven't, as far as criminality that haven't been exposed to. I went out to West Texas, worked out there for probably a year and a half, and then I had an opportunity to go down to the Valley to help expand and start up their psychology program down at Evans Regional Juvenile Center, which is great, and had opportunities to learn a whole nother culture. It really is. Kids from across the state, Dallas, Houston, all together in pods. I mean, and having to interact and learn new language, there's so much you can learn. Then left the state, came back, did some private stuff, went out to California, got my doctorate. Excuse me, did some similar work out there with the California Youth Authority. Is one of my practicums, which is great. The Northern Reception Unit. Went back to work with the state at TYC after my postdoc, and then took a job. Excuse me. Took a job here with took a job with the Corpus Christi State School because they started, which is a program for intellectually disabled individuals. Wow, this is great time.
Take your time. Take your time.
Cool. They opened up a forensic unit, so they started transferring. There was one other facility. They started transferring individuals that were incompetent to stand trial based on intellectual disability or autism to Corpus, and so I had an opportunity to come in and be the director of psychology, the director of behavioral services. So I came in and got to start that program. Was great. Loved the job. And always did some stuff privately on the side. Left the state in 2013 and started up private practice. And in private practice, I'd say we do a lot of varied individuals, meaning that everyone for the most part has some general work, but some very specific things they do as well. I personally do a whole lot of assessment nowadays. Post-COVID, I think we lost a lot of psychologists that do assessment. Not a lot of psychologists work with Medicaid, so I'm just kind of slammed. I had to make a choice between counseling and assessment, and I like assessment. This will pass, don't worry. My doctorate is from the California School of Professional Psychology, and I was in Alameda, Bay Area, California. It was very behavioral-based family systems type of work. And then I got a bunch of training when I worked with the state with behavioral principles, ABA types of stuff, and I found that that I tend to integrate a lot of that in a professional sense, and it works well with it. Okay. Questions about that? About me? Cool. Okay, so I feel like I understand this population pretty well. Our outline for today, we're going to obviously talk about cognitive behavior related disorders. We may kind of fly through this. Most of this stuff is diagnostic in nature, but it's good to know. It's worth knowing. And then we're going to talk about, and obviously part of that's going to be some treatment options at the end of that. Then we're going to jump into parent training, which from my perspective, it being in it and understanding the difficulty in making progress within the system, trying to understand what can we do to actually create evoke change. Really got towards treatment and prevention of all this. We're going to touch briefly on behavior analysis, applied behavior analysis, because it's seen, well, number one, because I like it. Number two, because it seems to be amongst the commonalities of application programs. And then talk about sort of a system of framework by which to put this together. So you walk away with an idea of things that you can actually do. To me, I think that's always important. You don't just want a history lesson. You don't want just to be educated, but you want something you can want. That's always and I'll lead with a caveat, just because we're hearing it doesn't mean we're going to be experts in it. If we like it and it seems to fit with us, with our personality and kind of our innate tendency to help others, it should then, catapult you into an area of this is something I need to look into this is something I should study to be part of my tool belt, and or this may be my, the dynamics that I choose to operate with. Okay, so our objectives to be able to discuss the related disorders. Number one, discuss commonalities amongst programs. We're talking about a number of different programs, some more than others, and also state and discuss the use of a parent training framework from a behavioral perspective. Cool. Okay, so we're going to jump into right away conduct and behavioral related disorders. There is an actual category within the DSM that covers these areas, and they include oppositional defiant disorder, intermittent explosive disorder, the fun ones, pyromania and kleptomania, and then conduct disorder. They also have a caveat to antisocial personality disorder. I don't like that that's in there. It doesn't go into it in depth. It refers to the personality disorder section. I know there is a segment of those individuals that have been diagnosed with conduct disorder that tend to lead to antisocial personality disorder. We're trying to avoid that. So let's jump. Okay, and then other related behavioral disorders. ADHD is a big one. We're not going to go into this specifically in depth, but OCD and related feeding, elimination, sleep, wake, substance use, everything's a behavior. But you're asking a behavior. So we're not going to go there. That's my humor. We're not necessarily going to go there to all of those things. But as you heard, and I could even argue that mood disorders are behavior related. Behavioral based thinking is behavior. I'm not that extreme, but there are those that would. We're not going to necessarily go into those, but I think that they hold some validity for consideration throughout this. The strategies that we're going to talk about are 100% applicable to anything behavior related. And then secondarily, as Dr. Graff alluded, these are all, they're comorbidities. They're all worth considering. Mood disorders, even to the extent of thought disorders, but ADHD, other neurodevelopmental types of disorders issues. So we can't, to me, it doesn't make sense to take anything off the table, rather be global, even though we have some specificity with respect to conduct and behavior specific. Okay, so I'm going to fly through some of these. Again, just so we have a good understanding. First, let me ask you this. How many of you guys have taken your graduate level abnormal or diagnostic class? Okay, cool. How much time do we spend on conduct and behavior related disorders? A class? Good, okay, good, okay. So then it's fair for me to go through this. Okay, cool. ODD is a pattern, of angry and irritable mood, argumentative, defiant behaviors, addictiveness that lasts at least 6 months. It's evidenced by at least 4 of these. Historically, you had to have like 1 in each category. Things have changed. We're not going back to historic. So when I spoke earlier about how DSM has maybe kind of gotten some liberal in some sense. We'll say the same thing, but you only have to have 4 of these symptoms. That you exhibited during interaction with at least 1 individual with symptoms. So angry, irritable mood, loses her temper, touchy, easily annoyed, bothered, anger, often shows anger and resentment. Argumentative, defiant behavior, argues with authority figures, defies, refuses to comply with requests, deliberately annoys others, again, who's not a sibling, and blames others, the locus of control. It's everyone else's fault. They did it to me. It's their fault. And then vindictiveness, spiteful, vindictive, at least twice in the past 6 months. So there are some notes in each of all of these diagnostic categories, and they will be on my slides, and I'm happy to provide all of that to you. If there's something of particular note, I will make sure. Most of this, it does have a little note of your children younger than 5. The behaviors have to occur most days for a period of at least 6 months, and we're just really looking for pattern, establishment of a pattern, its tendencies versus an incident, right, or multiple incidents. There are times as John alluded to, what do we do if it hasn't been 6 months? We would allude to this as some sort of adjustments, right? So that's where we typically start diagnostically adjustment disorder with, mixed disturbance of either mood and or conduct, things of that nature. This is after that 6 month period. Okay. In addition, so those were kind of the initial criteria. The disturbance in behaviors associated with distress in the individual or others in his or her immediate social context, meaning it is impacting various environments, right? Home, school, interpersonal, etc. Doesn't occur exclusively during another of these identified context disorders. Sometimes there are some diagnoses that do allow for overlap, but not for these. And then we have different specificity with respect to mild, it only occurs in one center, moderate, at least 2, severe, more than. Okay, so that's ODD. IED, intermittent explosive disorder, is recurrent behavioral outbursts represent a failure to control aggressive impulses as manifested by either verbal aggression towards others for at least a 3-month period of time, occurring twice a week, or 3 behavioral outbursts that involve damage or destruction of property and or physical assault occurring within a 12-month period of time. So we could have these outbursts, right, that aren't occurring all the time, but within a 12-month period of time, if we have these incidents, it would be the spirit of the and then the magnitude of the aggression is expressed during the recurrent outburst is way out of proportion. It doesn't make sense with the known truth. It's excessive. I would say that we see IED commonly diagnosed. Real quick, I would say that we see it diagnosed in kiddos, diagnosed when we have just explosive behavior that doesn't seem to be appropriate for the trigger of the situation. Recurrent episodes are not premeditated. It's not like someone's planned something. It's reactivity. It's just that boom. Like, whoa, what just happened? Recurrent aggressive outbursts cause marked distress in a number of situations. Typically 6 years or older. We always take into account developmental level. If someone additionally has an intellectual disability, they're not understanding the triggers, the antecedents, what's going on. We should be cautious to understand what all's going on with their perception of such. There are some diagnoses here that would limit your ability to make the IED diagnosis if the incidents occur were not better explained by MDD, bipolar, disruptive mood dysregulation disorder, which I think is one of those that's commonly mistaken. It's relatively new diagnosis with this new category. It's almost like temper tantrum disorder, if you will, in lay terms, quite applicable in many situations, etc. Diagnosis can be made in addition to the diagnosis of ADHD, conduct disorder, ODD, and autism when recurrent impulsive aggressive outbursts are in excess of those usually seen in the course of those other diagnoses, right? Again, just some little caveats, things that you can or cannot have unless it can stand on its own 2 feet per se, right? There are many times when we see someone, again, I'll use the intellectual disability or autism, that may not understand the severity of their reaction, their explosivity. And, you can have people side by side. Some people will say that, yes, you can have IDD, ASD, ADHD, ODD, etc. And a different presentation, the rules allow you to have it, but the understanding of and how it lines up may be better. Diagnostic stuff. I'm glad you all had a class. The books are everywhere. Feel free. They're terribly helpful. Okay. Pyromania. What do we know about pyromania? Obviously, you guys have heard about this, right? TVs, TV shows, etc. It is a deliberate, or some of the criteria include deliberate, purposeful fire setting on more than one occasion. And then there's some interesting things, tension or affective arousal before the act, meaning the fire setting is almost the consequence of tension, and or we see some sort of emotional arousal after the fact, right before we handle that. Fascination with, interest and curiosity about fire and its situations, pleasure, gratification, or relief with when setting fires or when witnessing fires. It's not done for monetary gain. It's not like burn down your building to get the insurance money and you're happy about that. This is different. Let's see, it's not about anger. It's not in response to delusion or hallucinatory types or any other sort of impaired judgment. Fire setting is not better explained by conduct disorder or a manic episode of antisocial personality disorder. So you can't have fire setting, right? That can be associated with conduct disorder, but you can't have pyromania that is not. So it just depends. Again, that's why we look deep and we really have to dissect what's going on. Kleptomania. Another one of the categories, recurrent failure to resist impulses to steal, essentially. Again, it breaks it down. Stealing objects that are not needed. You don't need it. Kind of like that kid of just stealing to steal. You know, it's the shiny object and they just take it, put it in their pocket. You don't really need it, right? I can think of kids that I know that have, like, you know, walked through stores and, you know, they steal, like, be like in a rock store, you just steal a random box. Really, what's the purpose of that? It's just, what do they say, sticky finger kind of thing. Increasing sense of tension immediately before committing theft, pleasure, gratification, or relief at the time. Not about anger, same sorts of things as the other, right? Not better explained by conduct disorder or manic episode or personality disorder. Okay, now we're gonna get to the big topic, conduct disorder. And again, we kind of alluded to this before, conduct disorder. We have multiple slides on this just to really set where we are. So it's a repetitive and persistent pattern of behavior in which the basic rights of others or major age-appropriate social norms, societal norms, or rules are violated as manifested by the presence of at least three. So as I stated before, you just have to have three of these criteria, and there's this patient that has 3 of the 15 within the past 12 months. The diagnosis did not used to be like that. You had to have a number in each category. So yeah, and then in addition to the 3 in the past 12 months, at least one of the criteria had to be present within the last 6 months. Okay, so I didn't really look, but the presumption would be that the application of conduct disorder is probably with the last iteration of the diagnosis. But of these criteria, aggression to people and animals, bullying, threatening, intimidating others, initiating physical fights, using a weapon that causes serious harm, that can cause, so you don't necessarily have to, right? So even just a threat, which a threat is an assault, you know, legally. So you don't necessarily have to do it, just the use of a weapon. Has been physically cruel to people and or animals, as alluded to in Raj's comment or story. Stolen while confronting a victim, like a mugging for snatching. This is where things start to get a lot more personal, right? You're going to take something off someone. Fighting there's typically a reason, but when you're going to take something from someone and look them in the eyes, it starts to take on a different dynamic, I guess, at least in my. And then force someone into sexual activity. Some of the remainder of the 15 criteria, destruction of property, is deliberately engaged in fire setting. Again, doesn't necessarily have to meet the criteria for pyromania, can be exclusively in the office of conduct disorder. And then deliberately destroyed others' property, deceitfulness or theft is the other category, broken into someone's house, building, car, vehicle. lie to obtain things, kind of running cons, stolen items of nominal value, without confronting, right? Shoplifting, et cetera, getting back to kleptomania, similar. And then this area that's really important, the serious violations of rules. Stay out late, breaking curfew, not caring about the rules. Obviously before the age of 13, then run away from home overnight at least twice while living in the parental or surrogate's home without returning for a lengthy period of time. And then often true from school, it's where we just kind of don't care, right? Those are the serious rule violations. And I think if I'm correct, this is one of those things that I didn't really see strongly in that example. Right, the serious rule, we had everything else, but whereas you would expect the serious rule, I would expect historically, diagnostically, would expect that to have to be included. It's not included. It's not a requirement to meet the spirit. I hope I'm not dating this. But Bailey said that she was not doing the same. Okay, so additional criteria obviously causes significant impairment in functioning. Most diagnosis, not only do you have to have the symptoms present, but it has to impair functioning across settings. Typically, again, as I stated, personal, social, interpersonal, school, etc. If the individual is 18 years or older, they don't meet the criteria for antisocial personality disorder. Kind of interesting. The diagnosis of antisocial personality disorder does not require. Don't believe that you have to be 18. There was a time that it was, but I think at least I've seen the application of it the use of it much more under the age of 18. Okay, then we have some specifiers, obviously, childhood onset. Whenever you see these, at least one of the symptoms prior to 10, don't necessarily have to have the diagnosis. This is interesting. You don't have to have the diagnosis made prior to 10 if you had the development of that 12-month period of time that did occur, or if you had any of these symptoms prior to 12, the diagnosis is allowed to include a childhood onset if it originated with symptoms prior to 10. Adolescent onset, I think, is some of the things that we see most commonly. Whereas prior to the age of 10, for the most part, there weren't any of those 15 symptoms. And then we have unspecified. Really, it's when you don't have enough data per se. I always have contention with NOS or any of these types of diagnosis, because it means that I haven't looked. I take that as I haven't looked deep enough to get the answer. And to me, understanding the accurate diagnosis, although there are times when you don't have the information, is quite important and helpful. Okay. It's a little bit smaller, but there are some other, if you will, specifiers with limited pro-social emotions. They are not showing appropriate sorts of outgoing, appropriately socialized kiddos or emotions, lack remorse or guilt. They can be callous or lack empathy, be unconcerned about performance. They really just don't care, apathetic to that right away. Or shallow, or they can be shallow and or have a lack of affect. Okay, so I would say in practice, I don't see the use of specifiers as much as we should. I think, as a clinician that does assessment, it's our job, as I stated before, to give as much information as possible, right? We should have dug deep enough that we have this data, because it informs the treatment providers. It helps them understand what's going on. It educates pediatricians, psychiatrists, community mental health, counselors, social workers, teachers, to the extent that they can see where it really is, and understand that the clinician who provided this diagnosis had gone to the lengths to get all this information. Tremendously. Okay. And then we have, intensity types of specifiers. Although if we're at conduct disorder, historically, I don't know that we really needed the mild, moderate category. But again, I think with some of the softening of this adds to the spirit of it. Or it helps further illustrate it. So mild, few of any conduct problems in excess of those required to make the diagnosis present. Fair, I would question the applicability of that. Did we have to go to conduct school, right? Moderate, a number of the conduct problems, and a severe, many of those are in excess. So again, further delineating what's going on with this diagnosis. Questions about the various diagnostable?
So, really quick. With conduct disorder, I see it in kids at my counseling site, and they don't really, at least not currently, they don't benefit from therapy because, they can't settle themselves enough to sit down and talk and work with anything. They just kick the door all day or punch holes in the wall all day. They're constantly being detained and things like that. So, I worry, like now you're 10, 11, 12, 13, but what happens when you can't get it under control and those adults? I've noticed a lot of the parents, they will like abandon their kids at the behavioral hospital because they don't know what to do with them. And there's really no medicine to help. So once they're adults, it's just crazy. Once they get in trouble.
Great question. Hard question. But you're absolutely right. I think that again, that speaks to, in my opinion, kind of the beauty of what I get to do. We need to figure out what are the other associated challenges, right? Just hearing what you said, I'm wondering, they can't sit still, they can't do all these things. Is ADHD a variable? Are we addressing ADHD? Are we addressing it sufficiently? Are there other mood reactivity types of things? There are a lot of things, not that I promote medicine, but there are a lot of things that can be done to, great example, little one that can't focus, speech is horrible, but they can lose their mind, they fall apart, they throw their only behavior, their only communication is behavior. They don't like something, they're throwing bits, kicking walls. It'd be great if they had words to say, not now, we're gonna like this, my head hurts. But we can't slow down enough to learn the words. And so sometimes there are certain things that different leaders use, medicine, mood stabilizers to help someone benefit from treatment. Not that that's what we do counseling, and not that I'm promoting that, but sometimes there are practitioners that think outside the box, and sometimes again, I'm not promoting any of that. But you're absolutely right. If we just continue to spin our wheels and everyone gives up hope and says, wow, this is just where it is, we need to think about RTC, residential treatment center. We need to think about long-term placement. Someone just take my kid, I'm returning him to the adoption center. That's unfortunate. And I think that there are many cases that could happen. I can think of many sectors of the state that I've seen that underprivileged neighborhoods, things of that nature, that it's almost epidemic in some situations. It's unfortunate, but again, the need to dig deeper to remediate what we can, so we have as much of a clean slate as possible to make progress. And it takes a collective of treatment professionals to make that. Right, yes, sir.
I was touching back what she said. I've seen that for adolescents, like 12, 13, where let's say this state like Driscoll or Bull Ridge, San Antonio, they have this child for over a month. The Bull Ridge private, right? Money. So what happens when they say we can't handle it?
So they don't say that, just to be critical of Laurel Ridge. They say that when the insurance stops paying, they send your kiddo back. When that really
They
happens.
told me that.
Okay, fair. Okay, so
And the state was paying.
gotcha.
So they told me that because her sexual aggression, even though she was 12,
Gotcha.
was so strong that we can't handle her. They straight up said, we can't handle her. We don't know what to do with her. And she's very threatening. And we want you to pick her up. I'm like, well, I'm having trouble. You have 24-hour surveillance on the child. What do you want me to do? What can I do?
So when that happened to you, you guys got the call, your treatment team got together. What were your brainstorming ideas? What came about?
You talk to the state and think, what can we do? What are resources?
Fair. I worked with the state at a facility, worked many times with the state. We've had situations where we would send, someone from, let's just say, a program to SASH, right? Okay, stabilization, see what we can do. And SASH, who should have everything available to them, didn't. And we would get feedback like that. And we're in the state too, right? We're a state facility. So it's what do we need to do? Who do we need to contract with? Where do we need to pull the expert from over here to come and do X, Y, Z, right? Staff training, behavior planning, one-on-one stuff, all of these things. You guys are the most restrictive environment. Let's not just think the most restrictive environment is going to do it. Well, let's inundate the system with the professionals who have demonstrated, more success in this area. So it gets back to reaching out and involving more professionals. Is there resistance in a case like that? Tremendous. There just is. But that gets back to when do we kind of wave the white flag? Well, I mean, if you're the end of the road as far as treatment provision, I don't know that you always get to wave the white flag entirely. You get to wave the yellow flag saying, let me find more help. In that situation, that would make sense to consult with other professionals from wherever. In your case, we have to, right? We can't just rely on, who's on call and what has been prescribed PRN and these sorts of things. We've got to think bigger picture. And that's a challenge, right? Thinking big picture, that exhausts resources. That does a lot of things that are not common. And QA are those people who, who authorize funding and finances don't always think out that they're black or white people. So we have to have someone that then comes in, right? But to create change here. That answer both of those?
Talk a little bit about ruling out. I'm hearing a lot of exclusives, is that all right? They want for this, they want for that. And really not much of any sort of consideration for their childhood or what they've been through.
We will be talking about that. Yeah.
Okay.
We start talking after I get through the parent training part. That's what when we talk about how to do parent training, it's not just what parents do, it's how do we motivate kiddo? How do we motivate parents? How do we get everyone to change what they're doing to see what? So yes, good, great question. Sure. Diagnostic questions? Cool. Okay. Onset of conduct disorder, real quick. You guys have read this. Can appear as early as preschool with some of these diagnoses, onsets way early. I'm gonna kind of fly through this. I hope y'all are cool with this. Prevalence, conduct disorder is like 2 to 10%. But that's a big chunk. That's a giant chunk. Potential, obviously, I think the average is 4%, but potentially 10% of kids could be diagnosed with conduct disorder. That's not what we want to hear. That's not the direction we're trying to go in. So at the very end, ask if you're motivated. I hope this number motivates you to do something, if at all, increase your awareness and be prepared and be able to when a colleague comes to you, say, try this, right? We don't have to have all the answers. We don't have to know where the answers are. We have to have some education to help people bring to me as treatment. That's from, I have little quotations. Causative factors, the next couple of slides have some overlap because different programs, but I'll just summarize some of this. There are experts that believe that there are a number of things that contribute to conduct disorder. Obviously, brain damage, trauma, genetic predisposition, child abuse, school failure, social problems, some frontal lobe stuff, traumatic experiences as stated before. And if y'all, in lieu of writing it down, I'm happy to send this to you guys if you want. You're welcome. Yeah, no problem, for sure. I'll actually send it to Dr. Cornwallis and someone can. Just I don't want you to have to write if I'm blind. Is that fair?
Well, plug it in the website.
Yeah, if they upload it, it already is en route to the Okay, more common in boys and girls, likely to develop in children or teens who are from disadvantaged, dysfunctional, or disorganized family units. Obviously some comorbidities, as we discussed previously, mood or anxiety disorders. Mood is anxiety disorders. So just mood disorder. PTSD, substance use, ADHD, learning problems really because our frustration is like, what am I gonna do if I am not learning? I'm getting in trouble and I've developed a reputation from the teachers, right? We know when you get that kid, it's like raw. He comes from a great family and everything's good and extracurricular, but he can't do it and he's picking on the kid next to him and then they don't like him and you're not going to birthday parties and you could just start this avalanche. There's so many little things that can contribute to this this presentation, right? And that's the complexity of it. There's no singular path. It's all these things that can come together, all the chips that can potentially fall that can lead us astray. Temperament, this says the same sort of things. We don't really know. Complex combination of genetic, biological, and environmental factors. I like that the best, right? It could be it could be just about anything. So that's a super concise question or answer. Can be inherited. All these things: impulsivity, temperament, aggression, insensitivity to punishment, which means they don't really care, which can also fall back on the type of punishment provided, in my opinion. Testosterone levels, TBI, just a number of things. Domestic violence, living in low social or economic environments, overcrowding, unemployment rates, all of the things that could potentially go wrong can contribute to be considered, at least in the literature, causative agents and risk factors associated with cause. Most of this repeats itself. Lack of impulse control, child abuse, parents who are using substances, poverty, things of those things. So again, I think it's an exhaustive list. I think we don't appreciate it, right? But to me, the takeaway from that is, number one, we don't have a single causative path, right? If that was the case, we would just avert the path, right? Just break that cycle. It can affect anyone from anywhere by and it typically is one or two relatively little things that start to build. But I love that slide because from a preventative stance, those are the things we need to focus on. And that's a lot of things. But that's why, as an individual practitioner, we don't need to be focused on one thing, not just me and my clientele. It's their relationships and those dyads and triads and school and community and extracurricular, all of those preventative things that are the glue that keep us. Prognosis depends on how early you intervene. Again, one of the reasons I'm going to talk about what we're going to talk about today. Early onset has a more poor prognosis, strongly associated with significant decline in school. Again, a contributing variable. Obviously, comorbidity, which we talked about. Further, to the extent that we're struggling with other mental health and or substance use issues, it's going to exacerbate and worsen potential prognosis for all of this. Long-term outlook for children. Again, I heard you got that. What this once treatment for chronic disorder or any other underlying condition we receive, your child has a much better chance of considerable improvement. We need to get in quick. We need to be identifying things, not just in the family unit, but in school, before we get to the hospital, where we're in the state. We need to be taking preventative action so that we can attempt to mitigate the eventual outcome, which is not positive. Personality disorder. Okay, so what do you do with conduct disorder or some of these behavioral disorders? The typical, we've kind of been talking, the typical course of action would be therapy, right? Therapy, counseling, psychotherapy, you know, and there are a variety of cognitive behavioral therapy included in there. Because, you know, there's just some research to support its efficacy with these disorders, but there are a number of derivatives, everything that's come off the cognitive behavioral scope. You guys are familiar with that, RET, all these other things. It all can be tremendously helpful, right? I mean, at least with respect to learning how to maybe better perceive or change our impression, perception of things, skills associated with that, problem solving, you know, thought balancing. There are a lot of understanding our cognitive distortions, thinking errors, etc. I see great value in it. Obviously, you guys do too. Additional types of treatment options include peer group therapy, peer supports. We see a lot of these, we see these in the community. We see most of these in substance abuse, in the field of substance abuse, right? Something that would be akin to AA and Al-Anon. But they also have something similar to this management, you know, peer-led stuff, where you have maybe a peer-led group, someone that's further along in this process of remediation, rehabilitation, that's leading and being able to be a guide, a model. A lot of those things we cite, there are a lot of it in juvenile corrections, a whole lot of these things where they're in facilities, they're pairing maybe like higher level individuals, behavioral based program, you have different level 1 through 4, so to speak. Pairing level 3s and 4s with level 0s and 1s, motivate them, show them the walk, how to work the system, etc., avoid pitfalls, things of that nature can be tremendously helpful. Some soft confrontations, some positive peer culture stuff, which is all tremendously beneficial. And then obviously anger management training. I think this is something that's throughout programming when we get into cognitive behavioral disorders. We can all use anger management training. And as new clinicians, we should all learn anger management techniques, calming strategies, verbal de-escalation. It's applicable to any and everything. The better you get at it, the better you can actually do it. We need to be modeling it to others to ensure that they're efficient. Impulse control strategies, things that we can do for ourselves. I would also include, impulse control, things that you can do to stop yourself, take a breath, think before you act, so to speak. Family therapy, again, I'm a big proponent of family therapy. And I think the biggest rationale, the reason I chose the program that I did for my doctorate was, I'm sorry. It's gonna happen all day. Is that I am a believer that yes, change occurs in an individual counseling session. True. I always worked with children, adolescents, and I saw my perception, personal perception, was that when I create an opportunity for change, return someone to their family unit environment, there's nothing to support or sustain that change. If I can create change in a room with everyone's roles to shift, whether it be structural, systematic, whatever it may be, and help get that system to operate in a more productive, efficient manner, the likelihood of sustained change when they leave is much greater. And so that's what led me. I spent many years with kiddos in my office and talk to them all 5 minutes before and after, and okay, cool, here's your homework, and they come back and show me what you did, show me what show me the skill set. Oh, well, let me tell you how the week, we'll talk about, wait, okay, we didn't get to do it because of this story, and it was just maddening. And so I started doing some things when before I went and got my doctorate. It was like, no, you're staying. You're not going to your car and working, taking the other daughter to ballet. It's like, I need y'all here. This is what we're going to do. And started doing more and more. My master's degree program didn't have a whole lot of family systems oriented work, but it was something that through consultation and supervision, I started looking more into, actually with Dr. Hill, started looking more into it. And really kind of found a passion in that. And let's change things in the room. Almost like if you're, for instance, a good example, I think it was like riding a motorcycle. Okay, cool. I'm holding the handle, right? I'm making the change. Every once in a while I let go and see where the family takes it. But then I'm grabbing it again, like, whoa, let's see where we're going. And kind of a little daredevil-y, but let's see where this goes. And but I'm right there so I can quickly realign what's going on, right? Am I going too slow? Am I drifting? What do I need to do to correct it? And so over time, the idea is not only am I instructing, modeling, providing feedback, which are the things we're going to talk about, but additionally, I'm letting them see when I intervene and why I'm intervening. So they see when quote unquote slippage starts to occur. They can start to self-correct. And that's what my feedback and modeling is supposed to help them. And so that's why I really just fell into the family therapy types of things. Other interventions, if you will, medication, right? I mean, obviously there is a time and place for medication. I think that what most people try to do in our field, in our realm, is avoid that at all costs, not avoid it at all costs, but try all lesser intrusive, lesser restrictive interventions. If we don't know when, if they win, we're going to get to service. There is always time to say win. And we need to know that essentially, we need to set the codes up so that we know when this case is going, we need to either revisit our treatment plan or incorporate them. It's just our.
I'm curious about all the points that like payment for the insurance company. There's only certain.
You mean reimbursement for a therapist?
Right. Well, just that they'll pay out so this person can see. You know what I mean? And all these things but I've never really got told like why do we do like reclassify to get them to see? And how come that hasn't changed?
So help me understand real quick. So reimbursement for greater levels of care.
Right, like say that you get seen, you're seeing them, you diagnose them, and that's like one of the diagnoses you give them, well, they're not gonna pay for that. Insurance for whatever reason.
Totally true. So that's, if I may, a great example would be adjustment disorder. Most insurance providers are not going to pay you for adjustment disorder. Applicable or not, the right time to intervene or not, right? They're based on a financial model that is antiquated and uninformed by the research. It's sad. That's when we should be intervening. We should be intervening when 6 weeks of therapy or whatever intervention is going to remediate it so they don't have to pay for 4 years of therapy, medications, hospitalization, RTC, etc. It's a beautiful question. It's a great legislative question. That's what it is. It's advocacy. It's one of those things that it's kind of funny. I'm gonna give a metaphor. When I worked in juvenile corrections in the Valley, we started to see a trend towards family members of kiddos working, keeping kiddos safe, gang clique members, protecting kids, get your education, get out. Teaching kiddos the way to get in the system is through administration. It's an alternate route. Same thing is applicable in changing laws. You guys got to get your education. You got to get out there. You've got to advocate. You've got to stick to your morals and your values such that when you get up to the lobbyist realm and or politics or whomever, that they don't just take the side deal because it's easier. It's going to benefit me. The mission is to benefit everyone and to do what's best for not the people benefiting or needing it now, but for the future. And we tend to lose track of our mission sometimes when we get too high. And politics, they're throwing in this with that and this. So focus, right? There's research out there that has been saying this for years. You wouldn't ask the question if you didn't know the answer, right? But why is it not happening? We get led astray. Alternate motives. But it is a great question. It is. And the further up, the insurance companies are going to pay one way or another, unfortunately. They have a model that says, oh, this doesn't necessarily need it, when in reality, if you're gonna talk to someone like me, this is when you do it. This is how you do it. And it gets back to one of the questions, and I think it was that Bailey asked, why aren't we doing this in elementary school? That's when we should be doing this. That's when we should, pediatricians, when you come in, and I see it, when you come in for your 2-year-old well check, they've got questions, but they need to be saying, okay, and now you're gonna go meet with the social worker and show me X, Y, and Z. Show me how you're redirecting. Show me these little things, because that's where the intervention needs to happen in preschool with littles, so that we're on the right trajectory. Can something still go wrong? Of course. But to the extent that we have a great foundation, we're in a better path. Make sense? Other questions pertaining to that? Cool. Okay, so other things in addition to medication, obviously community-based treatments, there are therapy at schools, hospitals, RTCs, like I said, residential treatment centers, short-term, long-term, all sorts of programs that are designed to, the longer the program, theory, you would think the greater the opportunity to generalize these skills to make change and sustain change. In theory, let's say that. It would be great, but then again, coming from a family systems, theoretical orientation, what are we doing with the family that we're eventually going to send the kiddo back to, right? That there needs to continue to be change there. The community, their eventual activities, the family, all of those things, relationships, siblings, all of them all have to change accordingly. Or we just took 9 months and a kiddo that's been on level 4, highest level, if you will, for 8 of those months, medications dialed in, doing great, send it back to the same thing, and boom, right back to where we were. Who has to assume liability for that? Every part of the system, in my opinion, all of it. It's all, we all did that work collectively, collaboratively, cooperatively to sustain the things. Now, is everything in a structured environment? Can we replicate everything? Of course not. No. But then we have to. So it's unfortunate when, like John had an example, they call you, okay, discharging tomorrow. What? It happens regularly in hospitals. Laura Reg will do it, need you to be up here, it's Tuesday at noon and you get a call, please be up here by 4 o'clock to discharge your kid. It's 3 hours away. Will be calling CPS if you're not here, ma'am. What? That's child abandonment. I can't get there then. And those are failures.
Yeah, I just wanted to ask this question. I know you have mentioned several times talking about the escalating, and I know talking about conduct disorder, one of the symptoms is like, anger, throwing tantrums. So in your own practice or your personal example, like you have a client come in and the person is throwing tantrum, punching the wall, hitting, how do you, go about de-escalating the situation?
So I think, so it's a good question, right? How do we go about de-escalating aggression, anger, aggression, et cetera, in the office? I don't think there's a simple answer. I think it's one of those things where we have to further investigate, not that we don't do it right then and there, but what's triggering the child? Is this anger? Is this a nonverbal kid that can't communicate? Is it kiddo doesn't want to be here? There are times when my practice, although in my mind there is a way it's supposed to go, it does not always go that way, right? It's mom or dad, feel free to take to the car, tablet. I've never met you guys before. I need to start somewhere, right? There are times when I have therapists that are going to the car and talking to the kid. There are times when we've gone to homes, we've met it where I can't go to a doctor's office and we meet somewhere else at a park. So we've got to get information so that we can understand some of the challenges, so that we can then create some sort of intervention, right? So do I make a kiddo throw a fit for 45 minutes in my office because I just want to see it? Right? Do I feed into the behavior? There are times that I will test theories, right? Like, hey mom, what do you do in this situation? Is what I usually do. Mom or dad, what do you do? Is there because very often I don't have to ask a question because mom or dad are like, oh, can he have his tablet? Can he do this? I guess that's what y'all always go to. That's helpful. You know, if we appease our kiddo, it's nice for me to see without having to prompt it. So a lot of the times they're trying to do something, but they feel like they can't do it in the doctor's office. Our office is way casual, so people feel pretty comfortable. I mean, I'm in shorts and flip flops every day, so people feel pretty casual to do things in my office. But I can see how, like Dr. Groff's office, great guy, but he's working Fourth Ward Driscoll, right, with psychiatry around him. It's much more of a formal setting. And I think that you might see something different, right? They've been in that same building to get shots, to draw blood, to do all these things, and it's just different people. So I can't really answer it specifically. We do a variety. I love seeing it, but I also love to see what moms naturally, I say mom, sorry, no offense, parents naturally gonna do, or providers naturally gonna do. There's times when they, you know, when there's a shy kid and I'm trying to interact with the kid and the kid's getting mad, that I'll stop, but then there's times that I'll test that theory again. And so I'm way active and dynamic in our and part of that's observation, part of that's taking notes, part of that's testing hypothesis, part of that's just gathering data. What, you know, and I'll let a kid calm down and then I'll go push a button. There's little things that right. I have a list in my head, but I don't always approach it sequentially. Right, it's about gathering. All of these treatment options used regularly all the time. Recidivism rates are still crazy high. What's recidivism? Blah, blah. Recurrence of behavior, right? So if it's going to happen again, I mean, so despite all of these things, with all the treatment efficacy, that's all beautiful and great, but if a third of the time it's still happening again, you know, if we're talking about, let's just 35% are those that have been incarcerated in juvenile corrections, et cetera, that re-offend, right? So 70% are those that just demonstrate behaviors again. But those that have been locked up for a period, not just a weekend, right, or overnight till mom got them out, but have been locked up for, I want to say it was like a week to 10 days, and were on probation, successful, did they repeat the offensive behavior? 35%.
Percentage. So what do you think is the percentage of cases that you're seeing that are court ordered?
The 35%. Yeah, those are ones that have been through the system and go back to the system.
Okay.
Yeah, despite all of these. So they're not, no, but the research that I'm alluding to, at 35%, the low end, are those that have been through the juvenile justice system and go back. Those that we see in the, I don't say, when I say we, I mean research. So those that research allude to 70% are those that just continue to demonstrate this, one of those 15 criteria. Does that make sense? May not necessarily be legal involved, may be legal involved, but still exhibit that one of those 15 criteria.
So high, is that because like somewhere along the way there was a part of treatment that wasn't effective, or is that just the nature of the diagnosis?
I didn't think so. Let me ask y'all, is the high recidivism rate based on ineffective treatment or complexity of diagnosis? What do y'all think?
A combination of what everything said, like you treatment, like you said, you got them up to 4, great, but outside of a controlled environment, all those rules you're trying to apply don't apply because you can't control everything. So, you know, that's when things go wrong.
So the answer is all. You can have horrible treatment that contributes. You can have the best treatment ever by the top treatment provider and go back to treatment, right? I mean, so, or you can have the worst treatment and come back to the best of, I mean, it just, there's no, that is the challenge.
Second, find that like effective treatment modify the systems around it.
Now, if we did comprehensive effective treatment, I think we'd see a significant decrease in those numbers. Yes. And that's kind of what we're about. Some of them, you know, what are things that we can do? So we set the stage. We know what it all is. We know all that. We feel the pitfalls right now, right? Hope is just like, what can we do about this? So prevention, one of the things we did, we just talked about this, helping systems, better treatment, you know, generalization of behavior, all of these things, combination of everything. Thank y'all for answering this in advance. Cool. Parent training. What we're gonna talk about, what is parent training? You know, there are a lot of different ways. So we talked about all those treatment things and how that leads to like 35% at best. We're gonna talk about a different approach. Again, as I've alluded to, maybe a little bit more preventative. What are things that we can do more holistically, more synergistically? But it's going to be about training parents. So we're going to talk about a bunch of things, nuts and bolts of parenting to some extent. I'd rather probably reserve that, but some skills, what to do, what not to do. You know, how do you train parents? There are many approaches. And I don't want y'all to ever fall victim to this, but this whole good enough parenting. If you're going to do parent training, make sure you're using an efficacious program. Don't just give behavioral tips and hints. Make sure there's something behind it. Expect everyone that you're providing interventions to, individual, family, group, expect them to take what you say and go look it up. And expect them to come back to you the next session and say, wow, I checked out that reference. Or what were you saying? Spell that name again. Even better. I have seen examples of therapists, quality therapists, that in their discussion with you will just be dropping research. It feels so great. They're saying names and you go and you look up that name and you're like, wow, you're not just winging it. This is not just about your experience. You're reading research, you're doing stuff. That is so, I mean, that just feels so beneficial, so helpful. Does everyone appreciate it? No. Are you as a therapist providing it? Feeling good about it? Yeah. Your stuff's real. You've done the work. You know what you're talking about. So I encourage that for sure. And then obviously adopting an efficacious approach and best practice. Okay, so kind of an introduction to this whole parenting idea. I'm going to talk briefly about parenting in a couple of programs. But then we're going to go into like some specifics. So we'll take a break and then we'll go to some specific stuff. Okay, so working with parents is a fact of life. If you think that you want to work with children or adolescents because you don't want to work with parents, you lost. I'm sorry, it's not going to work. I think that there was a time that people could get away with that, but I think there are great advocates that I know that challenge parents. No, a great example that blows me away. My little one, my littlest one, we put her in play therapy. She had an accident last year. She got hit with a hockey puck at one of the items, split her face open. And so, you know, she's got a big scar, not a big scar. She's got about a 3 and 2 inch scar. And some kids in kindergarten pick on her and they're like, you need, I'm like, toughen up, kid. But we decided to put her in play therapy for a little bit. And I took her one time and I'm sitting there in the lobby with my little one and the door opens. Come on, Ivy. And my kid disappeared. And I was like, huh? 45 minutes later, the door opened again. Here you go. Do I need to pay you? Do I give you feedback? Do you see you next week? Wow. If that happened in my office and there was at least 15 minutes face to face with a parent and a child, you just don't get anything. I'm a big believer in communication. What are we working on, etc. There are some models of therapy that's cool. That's all I'm missing. So if you don't expect to work with adults, don't work with children. You need to be working with the adults, the system. Effective parenting has been found to predict positive behavioral, social, emotional, academic adjustment, whereas ineffective, obviously the opposite. Later dysfunction, antisocial behavior. Training parents versus training trainers, a lot of literature, all sorts of things, conferences about these two topics. Parent training is defined as active, targeted teaching of specific parenting skills with the goals positively affecting child behavior. Training parents is one thing. Training, to me, and I would say this about anything. I could teach someone to do something. Let's just say, for instance, my 12-year-old, I can teach her to ride a bike. If I could teach my 12-year-old to teach someone else how to ride a bike, to be the teacher of the teacher, to be the trainer of the trainers, that person can is so much more efficient at this initial skill, but then they can provide the instruction, the modeling, the feedback, all of these things, so they're proficient. It's one thing to be good enough. It's another thing to be proficient. So I come from a school, if you're gonna learn something, learn to be the teacher of that, so that you know it, you can talk to others about it. Not that you're the expert at all. It's just proficiency. So that's kind of where I would come from. Major reference material with respect to all of this stuff is there. This book, I mean, I'm pulling out a lot of stuff, most of the stuff from here on out from that book. Why focus on parenting? Parents who demonstrate effective parenting behaviors, practices are more likely to have children that are well adapted, socially functioning, adolescents and adults, however, ineffective parenting are predictive of delinquency, school failure, antisocial behavior, adult psychology. Does that mean that parenting in and of itself is going to correct all things? No. What are we trying to do? We're trying to scoop as much of the good stuff off. They're predictive factors, right? They're protective. That's what we're trying to do. As far as theories, you guys have been through theories, right? You guys know I don't need to spend a whole lot of time because there's more important stuff we go through. Psychodynamics, theories of parenting, obviously humanistic, developmental, Piaget, Vygotsky, all these, and then behavioral, Skinner's work. Obviously, we're going to talk about that, but more where Skinner's work has been taken to apply towards people as opposed to the lab person. A lot of research on parenting attributes and characteristics such as intelligence, health, education, inclination towards substance abuse all contribute to that. Parenting style, I think, is a big variable, with authoritative being probably the best, and the permissive, both permissive styles being less effective or leading to less optimal outcomes, like I said. Not just, because there are very many authoritative and permissive parenting styles that happened to result in positive outcome, right? If we're going to choose our parenting style, we should probably choose that one, which is yielded the best outcome. That makes sense. That's kind of where we're going. What are things we can do? How can we actively avoid some of these pitfalls? And so that's kind of the ideology. Some environmental variables, sociocultural contributors, culture, ethnicity, family value variables, and then the parent-child interaction, I think is giant. All big things that were considered of primary importance at the onset of teaching parenting. The history of parenting really dates back to like the first psychology clinic in the United States, University of Pennsylvania in 1896, when the focus became included, when I would say the practice, the research shifted, albeit a small part, from the individual, the identified patient, the child that was the problem, to what can we do about that, sort of this more preventative approach. Child guidance, clinics, the Office of the Program for Prevention of Delinquency, way back then. There's a big expansion of mental health services to the schools, as Bailey mentioned. We still need to have more of that. It is Bailey, right?
Yeah.
I said your name earlier. You weren't here. I dropped it earlier. Obviously, psychodynamic behaviorism started to take trends. Then we started having university-based research, which is what we need, right? We should have, National Institute of Health research, which came along. Most things will start at the university level. That's what parenting is been.
So what is like an approach, maybe like a blurb that you often say to parents who are kind of resisting listening to what you have to say, or to people, like if you're suggesting training. So like also because it's like I'm always working with psychologists, so a lot of the time like the district I work for are even like a little involved to like not involved at all. And a lot of the referrals are teacher referrals. So getting the parent to even like complete surveys or questionnaires, or whatever, is really hard.
Sure.
So whatever, you get that done, but then you're gonna tell them, not you, like then we're telling them like, oh, this is wrong, not wrong. providing for the kid is what we're gonna do here, but how can I then say, but in the night, say, like, so what are you gonna do at home? That's,
So good question, kind of specific to a school setting, how do we motivate parents to become invested or at least involved? You know, so first of all, it's a broad question, obviously, but I like it. I think I have a decent answer. We have to, and we're gonna talk a little about this a little bit. We have to identify some commonality of our communication, right? What is this? What you're considering aggression, he does that at home, that's fine with his little brother. So they fight once in a while. So we have to have some common language, what we call it operationally defined behavior. To the extent that we have that, we have commonality. Also, I think that when in that situation, I think I'd be calling parents in, but not just sending forms and discussing the behavior. I'd be assessing defensiveness, cultural variables, what's accepted or not accepted, and then the potential impact on the behaviors having on the child's academic success, right? You wouldn't, in a school setting, you could have a diagnosis. The school doesn't really entertain the diagnosis until it's interfered with learning, right? So from a clinical and school are entirely different things. Y'all are saying, okay, qualifying diagnosis, tier 1, interfering with learning, about to fail, tier 3. We're qualifying you for service. We need you to be on board. What are you going to do to sustain this change at home? Once I think we get to that point, you know, using motivational interviewing techniques, using forecasting where things can go right or wrong, giving them the opportunity, but then the support. It's one of those things like if you say, hey, you just have to call your therapist, you just have to get this training. If they're at the point where they're just like, 8 to 3, I'm good. They got that kid. If they're there, hope is small. We still have to instill hope, which means probably the school putting forth, you know, counseling, education, linking community mental health, these sorts of things. There's no clear answer, and it's going to be very specific to the dynamics that happen when we meet. But we have to approach that very clearly. Anytime there's an ARD, it's typically everyone feels like this, and we need to be like this. What can we offer to help you? This is what we can offer to help in the school. What about at home? What kind of supports do you need? I've been at ARDs that have attorneys, you know, both parents' attorneys, due process attorney, TEA attorney, but also MHID, juvenile probation, the meetings that Claudia runs, the CRCG meetings where the whole community gets together to talk about specific cases. We don't want to have to get there, but we should almost begin with the end in mind. Who needs to be involved in these reparative talks? We don't want to have to get to that point to where it's that big, but if we have the players at the table, maybe we can avert going there. Does that make sense? So figuring out some commonalities, I think, is the best. And understanding, you know, where that parent per se is. If a parent is, hey, 8 to 3, please don't call me, I'm done. That's quite important, right? And the notion of them doing something, we have to find out number one, what's needed, and then how can we help you remediate it. Sure. Okay, so again, with the evolution, boom, boom, boom. You see some progress. Behavior family interventions really started to take off. 70s, 80s. Parenting is a complex topic that encompasses a wide range of skills, behaviors, attitudes, cognitions. There are tons of programs out there. I want to talk initially about some evidence-based, empirically supported programs. I know you guys are trained and educated this way. Things that have actual data, things that have been peer reviewed by quality reviewer, experimental design, meaning that we have compared treatment groups, control groups. We've done that over time. There's replication, so true statistical experimental stuff. And understanding the difference between ratings, observations, subjective measures versus subjective measures. These are some of the programs we want to look at. There are 4 in specific that I'm going to kind of compare and contrast really quick. Living with Children, Incredible Years, etc. I mean, each one will be out here. So Living with Children, it's really a program that was designed for 3 to 14-year-olds that had significant social aggression, to include all those. It really was working with individual families There was some work that had some group stuff, but it was really a therapist working, did a 90-minute intake and then did 6 to 12 brief 25-minute sessions in the home, or 12. So yeah, did 12 sessions and then did some follow-ups. They did 12 sessions with the family and then they did some follow-up to make sure that things were continuing to happen. They really emphasized teaching parents to understand the behavioral theory behind the techniques and a high level of contact between the parent and the practitioner, right? Obviously, you've got 12 sessions and then they're in your house for the 6th day to make sure that it's happening. So there's some, number one, the buy-in, but also the accountability. Use a point system, teaching data collection, way behavioral, but had good data, right? I'm not going to talk necessarily about the data. Incredible years. Their basic program for little ones that had disobedience, bedtime stealing, bedwetting, etc. They did parent group meetings in a clinical setting, 2-hour sessions, like 10 to 14 weeks. The difference here is that they actually had videotape modeling. So they used some technology, which was super cool. Collaboration between parents and practitioner was high, really relied on natural logical consequences, and relied on parents to teach problem solving strategies to the kids. This is a good program. I mean, it still is. When I say was, I want to say that there have been some additions to some of these. Great program. I love the fact that they incorporated some modeling. The next one, y'all may be a little more familiar with. The helping the non-compliant child, little ones, setting intensive clinic-based format. 1.5-hour sessions for 12 weeks. The child was included, whereas the other ones, the child wasn't necessarily as included until they started using technology. So that they go in the very first one, if you will, living with children. It was about teaching behavioral strategies and data collection. And if you did this, what was the impact? This one started having, more collaboration. They were recording stuff, sending it back to the practitioner, but it didn't really include the child. They were role playing. It's helping the non-compliant child started incorporating the child into it. So we could see what was happening and the impact of the interventions per se. Children are not the decision-making process of how it's implemented, but we did, they did teach skills to both the child and the parent, which is helpful. Kind of prevention and treatment focus, etc. These are all the manualized types of programs. And then parent-child interaction, which I had been trained with when I was in California going to school. I worked at a family clinic, and we did a lot of this. Littler ones, disruptive behaviors, worked intensively in a clinic-based setting and had about 90-minute sessions, 14 weeks. There was flexibility. The reason there had to be flexibility built in is it wasn't just learning skills. It wasn't just, okay, now we're chapter 2. We're in one room, the parents in the room with the kiddo with an earbud, and we're telling them what to do. We've already taught them why to do, but we're prompting them how to do it, when to do it, etc. And so you have to build in flexibility because your kids sometimes that is what you want them to do. Amazing. They don't always do it. Okay, so developmental and behavioral elements, how they're conceptualized and effective treatments. They offer direct coaching of parents, child dyads, practice compliance as a skill, high teaching skills. There were times when I was working at the Family Institute that we would go in as clinicians and model. So first we teach the parent, this is what we're going to be doing. This is why the sessions were long. We teach what's going on. We'd go in there, demonstrate the skill, come out, the kid would play where we're saying, okay, this is what I did. Rehash that. This is one of the pitfalls. If this happens, this is what to do, stop, etc. So it's somewhat of a script. They put the earbud in, we'd go in the other room. Typically it was one way. Not all rooms had one way, but they would have TVs, right? And cameras. So we could sit there and watch the TV and it would be a cohort of like 3 of us. And like, whoa, stop. It's really just, we're walking through how to do it. And then we'd stop and give them feedback. Great program for teaching skills so it's a beautiful program for also refining skills in parenting. Even when we're talking about say good job, praise, give them a high five, little things that reinforce the behavior.
Prior to, is there any point where you're assessing the parent and then recommending either prior to or in combination with individual therapy for the parent?
For sure.
At what, is that just like a?
Yeah, I would say it's probably regularly.
Okay,
Dr. Groff talked about things that make you uncomfortable or your vulnerabilities. If someone's not gonna be willing to do what I need them to do, what we have prescribed with respect to the treatment, we need to work on. Right, there, you know, and parenting is one of these things, it's, you know, there's a preponderance tendency towards parenting the way your parents parented.
Yeah.
Or the opposite. That's both of which can always be terribly effective, right? Sometimes we have to find middle ground and we have to understand why and what's been mutually beneficial to the kid and child. Why are we parenting one child differently than the other? So we have to look contextually at it, right? What are our experiences? A good example, you know, and I'll talk about it. The whole cultural question that was asked in the thing. It's not just about, to me, and then I'm happy to talk about this a little bit. Culture is not just where I came from, what I've historically been exposed to. It's the whole sociological, political, ecological, education, where I am, where others I know have been, what their experiences have been, my greater unit, my society, where I am with respect to my origin versus how I've, you know, assimilated or acculturated to this other, not necessarily dominant culture, but to this other, where I am in that process, where I shift in that process, and to the extent that we're uninformed or we assume. There's some data in here that talks about a chapter that talks about cultural implications and different ethnic groups and what they tend to, okay, that's good. But if I take that as it's written, I've done everyone a disservice, right? Our job, in my opinion, personal opinion and professional opinion, our job to be culturally aware is to continue to not know. It has to, I believe, you have to continue to ask because you guys, you're all here, right? We all come from different walks of life. We'll all return to different walks of life. We've all had different experiences. It is a combination of our entire learning. And it's informed not just by us, but generationally. And and some of us have ideas of where we can go and how we can change, and some of us have different ideas. And so we have to entertain all of those variables. And so that's in short is the answer to that question is we don't know until we do it in depth and sufficient comprehensive. But yes, I make those referrals all the time.
I'm kind of thinking about but whenever you do things like, hey, that's like the parents need to be parenting. I mean, parenting training or individual conference. What's your opinion about you doing it versus like getting another professional?
I'd love to be able to. I'd love to be able to do it because I think that I have good experience with it because I would love to be the one to do it because I feel informed, I feel educated in it, I feel competent in it. But I know that if I rely on myself alone to do it, I only touch a small portion. So I think that there's a professionally developmental phase in our life that some of us come to where since we acknowledge that we can't do it all, whether it's because I've got to do X, Y, and Z to pay for this kid to go to college and I don't get to go and, you know, work in the community center, et cetera, right? Sorry, I thought that was fine. That we try to train others, that we try to broaden the reach. I know that when I got y'all's email about this topic, I was like, yes, because I've already been, those agent therapists, I've got a couple of behavioral therapists that work at our clinic and like, we're 50, why are we crawling around on Legos? Like, stop. And COVID happened and I told my therapist, like, Monica, no, you're not doing 3-year-olds anymore. You're shifting, you're gonna start working with parents. You're gonna teach parents. And so we've adopted a big shift, our offices. We have parents come in, we're with parents and we're teaching the parents this stuff. And we're trying to put together a big curriculum so that's what quarter of all is. So I've got a therapist that does all the nuts and bolts, and like I talked about before, and like I'll talk about next, she's got all this stuff. And I said, well, then I'm going to put together the theory, and we're going to plug your stuff into my stuff so that we can present stuff like this at MHID, at hit that Bayview, and so that we can have a broader touch. Does that make sense? So to answer the question, I think that's kind of where we are at. See, this topic just landed in my lap, and I was like, yes, I think I responded within an hour. About pop up, and I was doing it intake, I was like, oh. Fair.
When they're like working, is it just like an alternative schedule, like you stay late, or like what do you do? If I do like try to do parent training at work, right? At
Sure.
school plan, and it's like, I don't work right now, I can't talk all the time. So it's like,
So yes, I would say again, great question. Yeah, I think that prior to COVID, with everyone being face to face, yeah, we would stay late. I go into the office. I'm probably in town 2 weekends a month, and I'm probably going to the office. I go in on Saturday and Sunday to do something, whether it's catch up on paperwork or if I've been, away for a week. Yeah, so we're in the office all the time. We're in the office. I have 3 files with me in case I have time just to do an intake on the phone to start the process. So we're always working. What we're shifting towards is recording parents training sessions so that we can have a curriculum to initiate, so that someone can go to our website, hit a hyperlink, and boom, see something and see it animated, not like mine, the stuff we're going to get to next, but boom, so that people can become more educated, more informed. So they have step 1 and 2, and we can refine step 3. Does that make sense? So that's kind of the direction that we are trying to go to with this parent training.
which also like make the most of the time of like. Yeah.
I mean, there's, I'm gonna get into it, but the whole instruction component, I can teach you what I'm gonna teach you. Just talking to you, I don't need to sit with you, right? I can sit in the screen and talk. I can model the behavior of what to do. I can't necessarily rehearse it via there and or provide feedback. Unless someone's sending me video clips back, right? And I'm refining it, just like instead of being in the earbud, I'm hitting it on Zoom, or we're blogging back and forth. Then I can, hey, when you're doing that, I can give them some direction. Is it better in person? Of course. Is it better with the kid like this program? Ideally. But something's better than nothing, right? Like, again, getting back to your question. Do I refer out? Yeah, but I'd love to do it because I know what I'm doing. I know. Does that make sense? But what I'm doing can't touch enough to make the change that we're all talking about. Cool. So commonalities, really important. Obviously, rooted in behavioral and social learning, positive interactions, praising, attending, rewarding, reducing reactivity to minor behaviors, like a giant thing. These programs also highlight the importance of reducing unnecessary demands by putting clear, by being clear when they have demands and compliance is expected. Immediate consequences and punishment, punishment is a consequence or intervention. Those things need to be immediate. Establishing contingencies, making sure that we have instruction, modeling, homework. These are programs that, a list of programs, I'm not going to go into them. They are great programs. They are fabulous programs. I know many people that have been trained in them, and they have tremendous, they work. They just really do work. They're just not empirically supported programs. They're more the manualized stuff. They don't have that. They don't all have the peer review. They don't all have the replication. They don't all have that efficacy that we're looking for, but they're still great. They're still all great programs. So that to me is important. These are great tools to have tool belt. But to me, before you employ the tools, you should have all the understanding. What's the basis for it? Does that make sense? Because you may need to pick and choose. Dr. Graff talked about being eclectic, which sounds better being integrative. But when you have to use something, you need something to pull out. So if you ever get into parent training, these are programs worth looking at for sure. Okay, so let's take a break. Can we take a quicker break? First of all, any questions about those programs? They'll be on there. Cool. So let's take like just a 5 or 6 minute break. Is that cool with y'all? Okay, cool. Just because I still got some stuff and the nuts and bolts of which I want to hear. Cool. Yes. No, you're good. Yeah. Cool. grab the notebook. You're good. Not a problem. Cool, okay, I think that's everyone. Perfect, okay. Sorry for the short break, got a lot of stuff, I think it's important. Okay, so next, we're gonna kind of shift, so we've talked about diagnostic stuff, right, which was that first quarter, we've now talked about, parent training programs and obviously some commonalities that are quality. We're gonna talk briefly about applied behavior analysis. And, applied behavior analysis is essentially where we took behaviorism from the lab and applied it to people, if you will, right? And how we use it is the only true science in this field, so to speak, that again meets all of those criteria. We have things that are coming along CBQ, we have some things that are very efficacious in moving towards this. ABM, we're gonna talk about antecedents. Among the antecedents include establishing operations, and I'll give you some definitions and examples, discriminative stimuli, and then consequences, positive reinforcement, negative reinforcement, extinction, then positive and negative functions. Okay, so the antecedent group. Establishing operations. What it does is it essentially establishes the value of consequences. It influences how much people may want something. It's typically attributed to deficit, if you will, something that motivates something. So a good example, if you're going without food becomes a great motivator. If you're going without, you're in a state of cold freezing, warmth becomes quite a motivator, quite much more value. Okay, so establishing operations is something that helps one indicate the need to do something, right? If you're in a state of deficit, you're willing to perform, to act in a heightened manner. Discriminative stimuli is something a little bit different. It is the signal that tells someone the best time to engage in a certain behavior because the value of that is great. To signal when certain responses will be most effective in achieving a desired consequence. Great example. So asking your grandmother versus your mother for a cookie, right? You ask your mom, you know the answer. You see your grandmother there, you're like, oh, okay. You go to the source that is a signal for the best outcome. So, or a good example, another one. If you're gonna wrestle, are you gonna wrestle with your sister or your brother, your little sister or your big brother if the outcome that you have, the desired outcome is to win, right? So we have these two things that are important to realize, establishing operations. So I'm trying to set this up so that we can conceptualize things to use, tools, so to speak, to use to set up optimal situations. And I don't want to go crazy deep into ABA, but I thought these are quite notable. Establishing operations, it's kind of a motivator, and discriminative stimuli is that signal, like the green light. Okay, now it's when you can operate. It's almost like when you're talking to your kid, or you're trying to teach them something, and you feel like the window's shut. You have to keep talking. You can't see the window; it's clear glass. You have to keep teaching them. When that window's open, they have this aha moment, right? So the window opening is like the discriminative portion of this. Okay, so then consequences. Consequences, 5 different kinds of consequences, and we're talking about how to use them, but reinforcement, extinction, then punishment. Reinforcement is something that increases the likelihood of a behavior occurring in the future, right? We have positive versus negative. Positive is additive, negative is taking away. They're both reinforcing, meaning they increase the likelihood of behavior occurring in the future. Positive reinforcement, present contingent. We present contingent based on behavior. So the behavior has to be there. You put something in, it increases likelihood of that behavior in the future. We're adding something that's desired, whether that be praise, touch, any of those things. Negative reinforcement, we remove something contingent on the behavior. It increases likelihood again. whenever we remove or prevent something undesirable, it's great for like an escape avoidance. So when your mom stops nagging with a clean room, right? We clean our room to avoid that. Reinforcement. Extinction is a removal of a reinforcer for a specific behavior. The behavior no longer gets the same result. Sometimes we have an extinction burst, right? If someone, let's just say a good example of the planned ignoring, stop attending to attention seeking tantrums. Kiddo in line, checking out an HEB, wants a piece of gum, throws a fit. You can reinforce that behavior. You can buy the gum. Sure, it socially feels better, I guess, but you better expect that is positive reinforcement, right? It's negative reinforcement. You in theory think. To extinguish that behavior, put that on extinction, you ignore it. Yes, that behavior may escalate. That kid may fall down. That's what we call an extinction burst. When they realize it's not going to work, the behavior of requesting to come in the line stops. So stop attending to might, and we're going to talk about how we use extinction. It's essentially for ignoring minor misbehavior. Positive punishment, we present punishment contingent on behavior, decreased likelihood of behavior. It's like adding something that's undesirable. Great example, spankings, things of this nature. I wouldn't say reprimands. And then negative punishment, again, it decreases the behavior from occurring in the future, but you're taking something away. You remove something contingent on the behavior, decreases behavior, removing something that's desirable, like grounding, restricting, take something they want away and insert punishing, which is deterring. Things that affect consequences, immediacy, right? So if you're going to administer consequences, they need to be immediate. The more immediate to the behavior, the better. The magnitude, it needs to be worthwhile to get their attention, right? If the consequence is minimal, not going to serve as a deterrent in the future. The quality has to be something that kind of stings for the kiddo, right? Let's say someone took video games away from me. Oh, whatever, good, whatever. I go play video games. Versus, let's just say my 12-year-old neighbor, you take his video games, that's like stealing his last breath of air. So it's one of those things, the quality of the consequence. And I would also condemn the reinforcer need to be quite applicable to the person. Frequency, begin with frequent reinforcement. The more frequent that we provide the reinforcement, the greater that contingency sets. Does that make sense? A good example, right? You're teaching your kiddo to go potty, right? We're having potty party every time they try. Then it's every time they go, and then we take an intermediate schedule ratio scale, and we decrease it once that behavior is going. But initially, all the time, reinforce, reward, way to go, good job. Then over time, we start to decrease the frequency of it because the behavior is occurring. Effort, make sure that the task is not too difficult. If our expectation is to climb, Mount Everest, and we've never climbed before, that's a little unrealistic, right? If, on the other hand, it's to take a step up one stair, right? Way to go. We reward that. The next time it's 2 steps. We can accomplish much more. If you set an unrealistic goal and fail, miss it, it's hard to then find the motivation to continue. So we want to be realistic. And then choice, obviously, consider feeding reinforcers and adjust the other 5 conditions. We want individuals to have choice whenever we're using it. Choice and/or influence, preference, things of that nature. They don't always get to be that involved with it, but these are some things to consider. Okay, so getting into some of the things we're going to talk about now. So the application of behavioral preference. The reason I told you some of those things, not that you need to know all of those things, but there are going to be some keywords throughout some of this. We want to use reinforcement to increase desired behavior. We want to catch them being good. We want praise. We want touch. We want points. We want to make things work for them. We want to have that frequency so that we get the behavior. It's like when we're teaching behaviors, we teach one part of a skill set. You don't just teach the whole skill usually. Sometimes you're teaching step one, step two, we're reinforcing along the way, and we're building what we call chain. We're also going to use extinction to decrease minor disruptive behaviors. Sometimes we're going to ignore minor misbehavior, right? Sometimes that's hard. I have very oftentimes moms roll their eyes at me when I tell them to ignore their 12-year-old daughter rolling their eyes at them. And it's like, well, you know, pick and choose your battle. Great example, my 12-year-old, tell her something she doesn't like. No, you're not going to spend another night at that kid's. No, it's 8 o'clock on Sunday. I'm not taking you to Target Nolta, and stomp it and goes upstairs. And I'm like, hey, turn the light off. She may stomp, she may do her thing. I'm not going to challenge every little thing she does wrong, right? Told her to turn the light off. She did. She can do that with a stomp. She can do that, whatever. She knows not to slam her door, right? She knows certain things. I don't need to chase every little behavior. Sometimes I pick my battles. Another example would be, let's say I have an employee that I'm critiquing something that they're doing, and they do it correctly, but they, you know, they're not doing it with a smile, and they're working solitary. Let's just say it's like completion of some documentation, you know, they're grumpy about it, but they're doing it. I didn't say do it with a smile on your face. I said, don't, right? Fix these progress notes. I don't like this. Sometimes we have to, you know, we've got to ignore some things, not all things, right? There's certain things that we can't ignore. You can't ignore self-injurious behavior. You can't ignore harm to self and others. So we're also going to talk about using antecedents effectively, which includes like stimulus control to increase command compliance. You know, when is that signal going to be applicable for that kid to know when to act? Good example of this is sometimes as parents, we get used to raising our voice. We prompt our kiddos 3, 4, 5 times, and by the 5th time, it's like, what are you doing? We teach our kids somewhat prompt dependent. It's like, you don't really have to do anything until I get to that level. I'm not going to step up and come and make you do this until I've yelled at you. Why do we do that to ourselves? Right? Our job would be, if I want to teach my kiddo, if I want to begin with the end in mind, and I want to teach my kiddo to respond to my prompt the first time, like, Kaya, need you to go X, Y, and Z. She doesn't do it, then I'm like, come on, kid, let's go. I'm not prompting her 3 times. I'm showing her, I already said this. Now we're going to do it. But eventually she'll learn, okay, when dad says my name, it's time to pay attention because it's going to happen. Another example of prompt dependence is, you know, why do we have these programs like, you know, Magic 1, 2, 3, right? That's fine, that works. But fast forward 30 years and the police officer pulls your kid over and, you know, he asks ID and insurance. Is the police officer going to ask 4 times? No, the kid's essentially waiting for the 3rd prompt. That's what they've been talking about. So let's begin with the end in mind. You want your kiddo to do something. Let's get them to do that. Show them that we're going to do it. Okay, just a little stimulus control. Use direct, simple commands, be consistent. Maintain your voice. Don't teach them to have tone or voice specific expectations. We shouldn't have to get upset. Then use punishment to decrease disruptive behaviors as necessary to include timeout and cost response. Behavioral skills training. So there are a lot of manuals that assist practitioners. That whole list before that I said are great programs. That assist practitioners by providing specific guidance about which behaviors and skills to teach and in which order, etc. You can go and meet with family and take one of those manualized approaches and teach them everything. It would be great. There may be 20 chapters of that. You may be teaching for 20 weeks, right? That could be, I could see how that could be a little excessive. I could see how that wouldn't be keeping in your mind short-term therapy and or the greatest good for the individual and use of their, you know, allocated sessions for the year, etc. To me, success depends upon whether the practitioner knows how to teach the skills, right? And whether or not the practitioner can motivate the parents, as we talked before, to use the skills. Those are some of the big things. Not just can we read it, like I talked about before, you got to be the trainer of the trainers. You've got to learn it. You don't learn it with the family. You learn it You teach someone, you practice it so that you know it like the back of your hand. You've got to be proficient, you've got to be more than proficient, say. And then how do we motivate people to do that? That's a big thing. You know, some ideas on motivation are being able to talk about success stories, being able to be so proficient at a skill that when the kiddo and the parent, if you will, are in your office, that you can show that behavior change. You can actually do something and they look at you like, what in the world did you just do? It's like, well, I got your child to sit down and be quiet for 30 seconds. I could do it. You know, it's not that. And so if you can show them, if you're that proficient, then you can show them that buy-in is right there. You can set that hook and then teach them how to do the exact same thing. To me, intake sessions are not just about gathering data. They're about someone walking away from my office with some, because that's the buy-in. People going away with not just what I say and great ideas, but or a homework sheet, but a skill, something they can apply or something that they can then use and they want to come back. We work a whole lot, as we talked about, with populations that may have lost hope, right? Populations that don't always, you know, treatment adherence and compliance is pretty low, right? If someone doesn't have to pay for any of their, and no offense, no judgment, nothing. If everything's handed to you and you don't really have to buy in and it's not going to change your life, we've got to sell ourselves. We've got to do some marketing. We've got to, you know, someone's got to want to come back. There's no one mandating you have to go to this counselor. The pediatrician just sent over a form and they follow them. Got to maybe come talk to me before we'll give you your medicine. Our job is to get them to strive to more. So, behavioral skills training. Teaching skills or teaching parents the skills that they need to be effective parenting typically requires 4 components. I alluded to these earlier. Instruction, we're going to talk about more modeling, practice, and feedback. What is instruction? Instruction is explaining what's going on, explaining, breaking it down, analyzing the components. So, yeah, I'm going to talk about these 4 and then I'm going to talk about them in context. So, analyzing the components. What are we doing? Why are we doing it? Starting with simple skills. The basics, then chaining those skills together to become more complex skills. It's almost like chaining is the opposite of systematic desensitization, right? We break something down to its component parts. We can do forward chaining, we can do backward chaining, depending on what skill set and what someone's natural inclination is. Sometimes you have to do certain things. Starting out doing forward chaining can be frustrating for someone, for the individual, because although they get to the end of reinforcement, they get there with support, whether hand over hand, whatever it may be. Backwards chaining is a little better because although logically it's different, it's I think forward chaining, yeah. Backward chaining, you can get to the reinforcement all. Yes.
So with a child that has already, the patterns are already set in place and they learn, like I can act out to get what I want, and then suddenly the parent just ignores, like, is that what you're supposed to do? You just change and you wait for them to follow suit, or?
So in most cases, I would instruct someone. So from behavioral stance, extinction is an intervention, right? To me, before we employ, if I just said, I want you to extinguish that behavior, and I haven't taught you an alternate skill set, then all you're going to do is the next, what could be wrong behavior, right? So to me, no, you don't just extinguish a behavior. You have to teach the appropriate way to gain access to that. So you have to teach the skill so that they practice the skill. Then you put that on extinction so that all they have is the way to gain access to tangible attention, whatever it is. So no, it's not just in the vacuum.
Okay.
We have to teach an alternate way to accomplish the same function.
In those times when the child is calm, so they can actually set.
Yeah, I don't really care if it was when they're calm or not. So yes, we teach it in calm. Yes, I'm sorry. Yes, but once they've got it, we change the paradigm changes. Once you know that someone has practiced the skill and they've got it, if they're still engaging in that behavior, then you just put it on extinction and they're forced to use their words. And sometimes teaching a kiddo to use their words in a line of HEB and not falling out. If they're using their words and that's what you teach your kid, you buy the gum, right? They just use their words, which is what you want versus behavioral falling out. Is that giving in? No, that's reinforcing a new skill, right? Then you continue to work in that with that realm because that's not your end goal. That's the step in the process. That make sense? Is that not giving in to teach your kiddo a new skill? It's the using reinforcement. Should we be using praise, touch, all these things? Sure, but sometimes we need to have a reinforcer that has the quality, like we talked about, the intensity to get that skill to work. We just have to understand that that step is not our end goal. It's a step in the process.
What
Good
if you're
question.
there's, like, you can't always, legally, you can't always give them something, let's say they want ice cream and they use their words, they don't throw a tantrum, but like you're getting, you can't do it. So then, if you don't follow through, does that like negate the reinforcement of that behavior?
So if you're teaching a new skill and you're inconsistent for whatever reason, it doesn't negate it. It's much more difficult if you lack consistency and frequency of your consequences. That makes sense. The consequence is a positive and negative. So yes, you will then have gone from a fixed ratio scale of 1 to 1. Every time they do it, they get this to this intermediate random, not 1 versus 3, 1 versus 5. Y'all remember all these inter schedules of ratio schedules, etc. You're going to an intermittent that we don't know what it is, and will they likely give up hope and revert back to the behavior? Possibly. So if you're going to be teaching a new skill, you've got to be ready to teach a new skill, right? But life happens. We're none of it. I can tell this. I'm not perfect. I know this stuff. We all slip. It's reality. We get back on the horse as quickly as we can, right? Yes, you're going to be on the phone sometime, and your kid's going to finally pee on a little potty, and you're not having the potty party. Is she ever gonna? Yes, she will still be able to pee again on the potty. Do we? Yeah. Can you say, hold on? Yes, there you go. Can you not do it immediate? Can you do it a couple minutes later? Of course. We have to. That's one of the big, to me, the big detrimental critiques of ABAs. It's so just black and white and technical. Well, you know what? Yes, in the laboratory setting it is, but in reality, it doesn't have to. We do the best we can. The better we do, the better we generalize it to the laboratory, the prescription and the outcome, the better we're going to get there, so that we then can go slip, trip, fall, make mistakes. And if we're going to be teaching a skill, and someone wants to teach their kid to go potty, I would say, hey, you got spring break coming up. You don't have to go to work. Dedicate your time to that. Be 100%. Be on it every hour. Do whatever you're going to do. If you can find time, you're going to optimize the eventual outcome. Does that make sense? Cool. Good answer. Decent. So instruction, describe the skill to be taught, provide a rationale why it's important, use written prescriptions, aids, etc. Instructions, that part that I said, if we were putting parenting on a hyperlink, instruction can be done from anywhere, right? This is why we're doing it, what's going on. The modeling is showing it, right? It's me showing a skill of how to get their child to sit, to attend, to do whatever. It's matching, we try to match the models with the parents as much as possible, but you can't always do that. We demonstrate each skill, we model it correct, we model it incorrect. We ask questions, which one is going to work? What was different? We try to help them discern what's, really going on. And model learning issue. And then rehearsal, practice, till they get comfortable. Practice easy skills first, build on that. The more you practice something away from your kiddo that you're going to be teaching them something new, the better you're going to be at it. Partial task, if you have really challenging, which means just doing part of the task, like the chaining, break it apart, do different components till you get good enough to get it together. And then practice outside the clinic, you take it home. And then the last big component is feedback, shaping the appropriate acquisition of the skill. Acquisition is how they learn the skill, how they acquire it. We need to make sure that we as teachers, trainers are making sure that they're getting it correct. And that I don't want to say using kid gloves, but if you come at someone wrong, where's their buy-in? You know what I mean? So sometimes we're giving them, initially we're giving praise, way to go, hey, I like good intention. Way to go. I like the way that you approached your child when everything else went wrong, right? It's the same sort of thing. You have to set the stage. So to speak. We use encouragement more than critique, especially at the onset. Descriptive, we try to be very specific, immediate with our feedback, and then obviously we prompt when necessary. Immediate with our feedback gets back to the beauty of like having a book. Okay, so those are kind of the 4 steps. This was kind of a question earlier. How do we enhance parent motivation? We got to develop rationales. Okay, you're not just gonna, it gets back to this whole thing. Hey, fix my job. I'm taking my other one to ballet. I'll be back. Like, no, wait a second. We have to convince the parent of the necessity of these actions. We have to let them see what's the benefit. If there's no buy-in, what's gonna happen? If hope is on the ground, everyone, this is what's accepted in my community. Everyone's doing this. No one's changing. Life goes on. We've got to set that rationale, and then we've got to choose language carefully. You guys hear me. I feel like I have a good grip on ABA. It has some technical jargon. I try not to use that. I don't talk like that. I hope I'm not talking too much like it here. I'm breaking stuff down. But I go to conferences and people are talking different language. I know it, but I don't do it every day. You break stuff down, especially if you're working with children. You just have to, and parents, because parents are, educated in ABA behavioral terms, and all the social implications. Who wants to hear someone talking a different language, some technical jargon? My opinion, personally and professionally, we don't do that. Okay, other barriers to treatment adherence, and then we're going to get into some good stuff. Looking at contingencies that control the parent, not just the child, right? We're talking behavioral. It's not just what we need to do with the child, but what contingencies, what is supporting the parents continuing to do or not do what they do, which may inadvertently contribute to the child doing what they're doing, right? It's a system. Again, getting back to family systems, it's all part of the system. What's the rationale? Parents are part of the solution. It's important to learn new skills. Practice is important to success. When you're trying to get people to do something new, you've got to practice it. You've got to create new habits. You've got to, great example, I talk about deep breathing exercises and teach people deep breathing or some sort of calming strategy. And they come back, oh, well, it didn't work. Wait, it's like the only way it's got to work is if you do it 5 times a day for the next 30 days, then you'll have a tool. I'm giving you a tool for next month. You practice it when you need it, when you don't need it, and when you're going to sleep. If you do it 150 times, your mind will start to associate with the rest of your body. 3 breaths in, oh, but you can't just use it tomorrow. It's not gonna work. That's not designed. But if someone had the idea, oh, he taught me this breathing, I'm good. The next day, are they gonna prescribe to my breathing technique if it didn't work? No, they quit right then. So we've got to set that stage. How we use language in session. We've got to be able to predict outcomes. There are going to be kids that fall out in the aisle at HEB. We've got to know that's going to happen. Predict social disapproval. It's gonna sting us. We're gonna be embarrassed, but it's for the greater good. Kid falls out at HEB. Everyone's kid falls out at HEB. That's just reality. Don't take it personally, right? Step over your kid. Success with skill development takes time, and obviously reminders, reaching out, etc. All the things we can do to keep them engaged. Other barriers, we've got to build rapport. We've got to use some sort of doesn't have to be money, but some sort of incentive to get them to use it. Technology is great, like I talked about. Also, different monitors, resources, groups. Nowadays, emails. Hey, how's it going? What's the progress? All these things that are easy, and then being flexible, like we talked about. Do we work after hours, weekends? Yeah. Cultural issues that can affect some of this training. We've got to recognize that all individuals, including themselves, are influenced historically, ecologically, socio-politically, and disciplinary aspects of culture. We've got to be aware of that. Information, recommendations, grounding in related social, educational, familial, legal context, shape experiences across the settings. Like I said before, I think that comment is probably more. I like my comment better than sort of the books that don't ever assume you are, that you know what you know. Ask questions, validate, It's just like communication. We've got to ask, inquire, clarify, validate, back and forth till both people are nodding their head. That's when you understand that what you just spoke about, which will then be different, the next hour, because we're all products of our continued learning. Okay. Non-compliance, gosh. There's a wide range of, what we're seeing. So we developed a framework. The framework includes things, so the general areas, you guys don't mind if I fast forward to this, cool. What to teach, why it works, and how to teach it, behavioral training. So what to teach begins with the review of literature. You've got to have good information, formulate a plan of what to teach, start to remediate some of the components of the problem behavior, work towards the parent goal behavior. Why it works, identify whether intervention components drive the literature. But we've got to use reinforcement, extinction, stimulus, control, and punishment. This is where those are coming in. And then how to teach. What are you teaching using the behavioral skills? So I'm going to give you an example about non-compliance. I have another example, but we'll see where we go with that. So for teaching how to get, we have a child that's non-compliant. Kind of basic stuff. It won't do what you ask them to. What to teach, right? I abbreviated that. You got to teach parents social attending skills, how to use praise, how to, use positive touch, descriptions, reflections, contingent upon compliant behavior. We're teaching what we want them to do for the right behavior. We're addressing the wrong behavior, right? So we're focusing on giving them attention for what they're doing right, the replacement behavior. That makes sense? We talked about how do we teach the kid how we use extinction. We teach them how to get it right. That's what we're doing here. Then we reinforce it. We provide social attention is delivered contingent upon compliance or other desired child behaviors, which increases likelihood of recurring. Then how to teach. We describe, provide rationale for using. That's to the parent. We present information orally, provide handouts. So we're breaking it down why we're doing this, that we model the behavior. Then we're rehearsing it, going on and on. Have parents practice social attention skills daily at home. Then we're providing feedback. All this initially takes place in the office. Again, as we talked about, and then we're starting to generalize it. Once they're proficient, right? Once they're proficient with some basic stuff, we tell them to take the basic stuff out in the world, right? Then we start doing the same thing in the clinic office, or it's maybe some more technical, more difficult areas. Once we're proficient, then we take it out. We need to make sure that no one leaves our modeling rehearsal sessions without being competent in the office. We don't want to then generalize it with more variables, right? The environment, audience, escape, all these other things. We have to learn it the right way before we go out and practice it. Then we come back and we make sure that we got it right. So that was the first part. That was the instruction, if you will. What to teach? We teach parents how to ignore minor behaviors through extinction. Why it works. Why it works is extinction. Removal of social attention, contingent upon non-compliance, etc. How to teach it. Describe the reasoning for ignoring minor behavior. And what social attention can do, or differential social attention. Model it. We demonstrate how to do it in the office. Rehearsal, have the parent practice doing it. And then feedback. We're going to just follow that trend all throughout. How to teach parents to provide direct one-step commands, how to get your child. You have already, the first step was teach them how to do the right thing. Second step is you start to ignore the minor stuff. Now we're teaching them when to do it. When's the best time? That stimulus control and signal. A parent commands that signals, reinforcement is available for compliance. So it's like, okay, now I need you to do the skill. We give them the rationale, we show it, we rehearse it, we practice feedback. Nice and easy. Then how do we apply? We teach parents how to apply timeout contingent upon non-compliance, punishment, same sort of thing. The instructions, we talk about it, we teach it, we practice it, we model it. When I talk about practice, modeling is me showing them. Practice is them essentially showing me before they're showing me what they do with their child, right? So so we have multiple stages to that because we really want to make sure that they get it. In my slide, I have a whole, goes to the same other stuff for picky eating. And the book has everything from examples for bedwetting, it just goes on. So breaks down some of these steps. I'm not gonna talk about practitioner characteristics. The important thing here is to know yourself, know your level of training, know when you need to call when, right? Don't assume as but all sorts of things that you can then use. How do we convert all of this stuff into practice? So we had those behavioral skills. Obviously, we've got to be doing a comprehensive assessment. We kind of talked about that. If you don't have all the information, you don't have all the data, you could be teaching the wrong things at the wrong time. You've got to be able to prioritize, essentially triage. What are the big things that we need to work on? Operationally defined behaviors, like we talked about before. We've got to be talking the same language, right? My aggression may not be the same as your aggression, right? But if we're going to work together, we've got to operationally define what is aggression so that our data looks the same. Define the goals for the parent, etc. We've got to learn how to monitor behavior. We've got to not only practice teaching strategies, but we've got to collect baseline data. We've got to figure out what's the state of this behavioral challenge now, so that we can then, that's our baseline data, so we can compare it over time. So that we can determine if we're looking at two different things. When you're teaching a skill, the more you teach the skill, the behavior should drop. Converse relationship, right? If you're teaching the skill, the behavior is sustained at the same rate, that's the wrong skill, right? If I'm teaching the skill and my behavior goes down, good. Okay, then I get to a point that we've predetermined, and then I need to start to generalize it or do something different. But you have to look at that converse relationship, or we're not really making progress. And then this, yeah. Then we have to identify, this is the difficult part, finding out what do we interest. This is what really relies on practitioner skill and experience. Finding out what's a functionally equivalent replacement behavior, what to help the kiddo accomplish the same goal without the adverse negative behavior, and or what are some skill deficits that we can teach. I don't want to say you could go wrong here, but you may not be as efficient as possible if we're just teaching random skills. It goes back to kind of like if I just have a manual and I teach the 20 chapters, probably covered a lot of the stuff, but the applicability, and did I lose my audience, so to speak, right? If I lost my audience, then what did I really do? Wasted 20 sessions, maybe they'll try it, maybe they won't, etc. So kind of just the applicability of the interventions. Training parents gets back to instructions. This is where that whole component that I pulled in comes into place in this big framework. Making sure you're aware of the barriers and then what to do with that. And then, this kind of gets into the more behavioral planning stuff, data collection, looking at, adherence to the program fidelity, as well as adherence to that we're making sure we're doing the right thing, moving in the right direction. We review data a lot. You make data-based decisions on how to continue programs, with stop programs, etc. You're looking at the data. If I met my objective, good. What system supports can I plug in so that this other intervention can be made? I can make that intervention, but sustain the outcome. Makes sense. We start to fade away. Boom, some stuff about research, etc. I kind of expedited all of this. I think you guys got it though, right? How to use that skill set. It'll be on there so y'all can review. And I wanted to do that just so that I can sit here and answer questions. Cool. So threw a lot at y'all this last hour. But I felt it necessary to really set the stage so that you can understand that. We talked about assessment and some of those things earlier with our previous discussion. The big part to me, the differential, is how to teach parents what to do. Part of teaching parents what to do is having a system, that instruction, the modeling, rehearsal, and feedback. But then if you don't have the expertise, you've got to have data to go to teach. So this teaching framework it should be applicable towards everything. The big question is, how do I know what to teach? I like the use of some of those manuals. I really do. I like being able to do an assessment that informs what you need primarily. Secondarily would be use of manuals. But following this frame is ideal. And then understanding some of the other variables, like what gets in the way. There are a lot of things that could be. But if you look at parent training as a preventative, proactive approach to get everyone on board, there's some data, I don't know, it helps with behavioral related disorders and conduct disorders. It's probably has the greatest change factors. The difficulty is that we don't look solely at parenting as a predictor of conduct. Right? Everyone looks at it. Cool. So questions? Yes.
So, there's a toddler that I work with, and you're talking about the point systems and the writing plays and things like that. When it's like way back, but this child in particular, very like demanding, doesn't seem to care about praise at all. It's not like what motivates him. And also like, it's too young to like comprehend the point system thing, right? So would you just like find what would motivate them? Like find what they would respond to or?
So to me, the big question is why are we using a point system that lacks the quality for the individual? We need to be using some sort of reinforcer that adds value. To me, points are easy because anyone can apply points. When I'm trying to change behavior with a little one, reinforcement needs to occur immediately. It needs to be immediate. And maybe that means, Skittle, M&M, all until we set it, then start to fade away. If we're going towards points tell me that you have to earn enough points to gain access to something. A 2-year-old's ability to forecast, oh, if I get 10 points a day, on Friday, mom and dad will take me to Peter Piper Pizza. Right? So we need to set it so that we're essentially performing the task. Then we start changing our ratios for longer. But if you don't, and you'll very often find that the novelty of a reinforcer will extinguish over time. It's like, oh, I've already had 200 M&Ms, right?
Yeah.
It's like, that's not gonna,
Right.
So we got to switch reinforcers, whether it's, even bigger kids, TV time, iPad, you've got to switch things up. I hear all the time, well, that works for 2 weeks, but it didn't work anymore. It's like, well, yeah, I mean, they've had 400 Skittles. It's time to switch something around. The system, the science works. The reinforcers have to change, and then we have to fade away once the skill becomes flawed.
Yeah, it's harder to find like those that get reinforced, but I think you can say like, well, if you do this, we can go get ice cream later, but like you said, like the foresight and the ability to remember that it's like not there.
And when we do stuff in schools, it's like, we're not going to give, encourage evidence at school, but there can be points and there can be breakdowns. Like you don't have to have a great day. We're looking at a quarter of the day, and then we build to a half the day, to a full day to go and, eat lunch or extra time to pee or whatever it is that's reinforcing. The key is you almost have to do a preference assessment, a reinforcer assessment to figure out what are the top priority items, preferences that you can then apply as reinforcers. And you can't just have one. If you have one, you will have a program for about a week.
One out of 1%.
Yeah.
Thank you.
Sure. Other questions? I feel like I threw a lot at y'all at the end. Cool. So anyone motivated to work with conduct disorder and behavioral challenges? But you can't say no. They're everywhere now. It's 10%. Anyone encouraged to work with parents? No. Well, I hope at the very least this gives you somewhat of number one, an understanding of the complexity, right? There's a lot out there. But I will also say that this sort of complexity is applicable to working with an individual and understanding contextually where they are. Just because you're working with an individual doesn't mean that you're not going to hear about family dynamics, work dynamics, all of these things. You don't have to have everyone in the room, but you have to consider everything that's taking place, right? It's all additive. We are all, in my opinion, a function of our learned history. And that's not just our personal experience, but others around us experience. And we need to be aware of that, or we're somewhat doing it disservice. It's a lot of work what we do.
Yeah, not a question, but just a comment. I really like the incorporation of teaching the parents because I feel like that's actually the key we as clinician, we only see that, like just once a week, or maybe they do it a week or 1 month, we just spend out 1 hour out of how many hours they have in a week, so the parents are the one who spend the majority of the time with them, so empowering the parents and, equipping them with the right tool for them to use with their kid, I feel like that is really the ultimate, and that's what.
So, yes, I love that, right? We have 1 hour, they have 175. But I would also take this model, and I use this model in supervision, train clinicians. This model makes sense to train not just parents, but teachers. I mean, that model, if you will, behavioral skills training, instruction, modeling, rehearsal, feedback. That's what coaches do. It's if you step back, that's what happens. It's really just formalizing it and understanding it, and then figuring out what you. And we use reinforcer, use extinction, a pitching coach. It's talking, when you're teaching a kid how to pitch baseball, getting it across the base, across the plate, way to go, way to go. Then they start to pull away from way to go, you made it in the strike zone, to refining that, modeling it, showing them how to stand, breaking apart that skill to where, you're pitching with just your feet, so or off your knees, breaking it down, so you're developing certain things to the point that you then collate in all and are just providing certain things. So it's applicable to all sorts of coaching and performance. I would say human resources, management training, all of those things. It's teaching is, if you learn teaching, if you learn some of these things, refine it, you can apply it to which is better. Cool. Other questions? Perfect.
Thank you so much.
Sure, hope it was helpful.
If you're willing to share your email address, would you be willing to do that just so students can get a hold of you?
Yeah, I can do